So without further ado, I'd like to welcome you all. The purpose of our talk today is to discuss how collaborative approaches for children with autism can lead to more skill building and hence a reduction in problematic behaviors. This is something that for those of us in the field and those of us who are touched by autism understand that, skill building is a major area of emphasis, as well as reducing problematic behaviors. So I'd like to introduce our panel this evening. We have some amazing speakers this evening. Dr. Mark Mintz is the founder and the chief medical officer at Neuroabilities Healthcare. He is quadruple board certified in neurology with special qualifications in child neurology, pediatrics, neurodevelopmental disabilities, and epilepsy. Dr. Mintz has also been on the faculty of several medical schools, and he is widely published in the medical literature. His interests include neurodevelopmental and intellectual disabilities, autism, epilepsy, brain injury, and concussions. His entire bio is probably about 7 pages long, so I'm just giving you some of those highlights. So we're very thankful to have Dr. Mintz. Dr. Greg Alberts also is here with us. He is the Director of Neuropsychological Services at Neuroabilities Healthcare. He has a PhD in clinical psychology and has specialized training in behavior therapy and clinical neuropsychology. He completed his internship with behavior medicine. We're very excited to have Dr. Alberts here. He's practiced in the field of clinical psychology, forensic, and neuropsychology for over 20 years, but he doesn't look a day over age 20. And he's provided services in rehabilitation settings, inpatient, outpatient, and community. Dr. Kaori Nepo is a board certified behavior analyst with a doctoral designation. Dr. Nepo is the Director of Behavior Services at Neuroabilities Healthcare. She has worked in the field of psychology and behavior analysis for over 20 years as a therapist, consultant, researcher, and university faculty. So welcome to all of our panelists, and we want to thank Colleen Shin, who is the Outreach Director of Autism Speaks, for giving us this opportunity and for joining us because you have such an amazing amount of resources. So thank you to Colleen and to Autism Speaks. So to get started, we did have a bunch of questions that were provided to us beforehand, and thank you to everybody who provided some insight into the things that you were looking for. We will attempt to answer some of those questions throughout the presentation, but I'd like to start off kind of at the beginning. So when we're talking about the journey of autism from diagnostics through treatment, we have to start at the beginning and discuss what exactly is it that we're talking about from a diagnostic perspective. So considering we have such an amazing amount of experience on the line, Dr. Mintz, I'd like to start with you. Beginning with the diagnostic journey for an individual with autism, when do we need to look to a neurologist? Mark, you on mute.
Sorry about that. Yeah, the short answer to that would be yes. But the more extensive answer would be that, as many of you know in the audience, that the autism has, many years ago when it was first, even before it was actually described, most kids who had autism, what we now know as autism, were described as being psychotic, schizophrenic. Then that evolved to a situation where it was beginning to be blamed as a psychological disorder, that their mother wasn't nurturing them as much as they should have, what was called way back in the mid 20th century, the refrigerator mothers. But in the last 50 years, it's well known now that autism is really a neurobiological disorder of early brain development. So in that sense, since we are dealing with something that is coming from the brain, neurological involvement, investigation, understanding is very important if we're going to understand the full spectrum of how autism manifests. And more importantly, autism, the way it's being described as a diagnosis, is really just a set of behavioral developmental features that is a final common pathway of many, many different biological and neurological causes. So we really need to understand what's underlying all this, and not just the expression, not just the behavioral and developmental expression, but actually what are the causes. So by going and understanding the neurology of this, getting neurological evaluations, you could start to answer some of the questions of the why, the how, and the when that often are very important for families. But more importantly, it can inform clinical management. both maybe certain types of tests that can be done, certain type of treatments that can be offered based upon the biology. And many different analogies I could give you, but one would be if you have an allergy, you could go and get symptomatic treatment for your allergy. You could get something to alleviate the stuffy nose, the sneezing, and some of the other problematic allergy symptoms. But if you go go and look for the biological cause of your allergy, if you understand what's causing your allergy, then you could eliminate that, and then all your allergies will go away. So autism in some ways is loosely analogous to that type of process. If you can understand what's causing it, you might be able to attack the cause, possibly lessen the concept of autism, but definitely help in many different ways attack the different complication manifestations of autism. So not only does neurological investigation and evaluation provide diagnostic information, but it could also inform how we should manage individuals with autism. So along those lines, how do you go about this? Well, one thing is really to understand what is the output of the brain? How can we measure that? Is there ways to do that? And there are objective ways to do that. And I'm going to turn it over to Dr. Alberts to talk about how a neuropsychological investigation can help understand and measure the output of the brain.
Thank you, Mark, for that transition. As you pointed out, Mark, the role of neurology, the role kind of the medical side of this equation is sort of obviously multifactorial. A lot of it having to do with sort of underlying mechanisms and causation and so on. The role of neuropsychology is obviously a bit different, but certainly collaborative and supplements the medical neurological perspective and approach. So let me comment just quickly for those in the audience. I'm assuming many of you know about neuropsychology or you've had experience with neuropsychological evaluation, but for those of you who have not, sort of just a kind of a quick definition here is that neuropsychology is a subspecialty of psychology, of course. Most of us who practice neuropsychology are trained as clinical psychologists or school psychologists or say counseling psychologists, and then go on to get subsequent training and specialization in sort of a different set of tested measures that are a bit more sensitive to brain functioning, to neurological functioning, and say cover a sort of broader spectrum of behavior. The measures as well that we use tend to be sensitive to brain functioning, not exclusively, but certainly can help pinpoint areas of deficit in strength at the neurological level and so on. So we use a specialized set of tools, as I said, but beyond just administering tests and administering measures, what we also do, I think that's unique to neuropsychology, is take our knowledge of neural development, of child development in particular, neuropathology, neuroanatomy, and so on. And on the basis of an assessment protocol, usually that's fairly extensive, taking anywhere from 3 to say 8 hours in a typical case, try to develop a profile of strengths and weaknesses of that individual subject, that individual patient. And on the basis of that, hopefully be somewhat prescriptive in terms of what we recommend on the basis of those findings, and as well descriptive in terms of trying to quantify and describe in as much detail as we can areas of functioning that represent proficiencies for that individual, but as well areas that may reflect deficits and deficiencies. And just to comment just briefly in some of the areas that we cover in terms of an evaluation. And this list is not exhaustive, but it's fairly lengthy. But from a typical evaluation of a individual with autism or suspected autism would probably involve IQ assessment to get a general level of intellectual functioning. We also look at attention skills. There's different ways of looking at attention. There's visual attention, auditory attention, sustained attention, divided attention. We can actually look at the capacity for individuals to resist distractions or resist focusing on distracting events in the environment. We can measure language skills with some degree of precision. Visual memory being one area, auditory or listening memory being another area. There's a dimension, usually part of an IQ battery, that consists of working memory or more short-term storage and focusing. Language is a major area that we look at in terms of our investigations. language output or expressive language, vocabulary development, and so on, listening comprehension, receptive language abilities, and the like. But even more importantly for kids and or adults with autism, this broad sort of concept of language functioning also includes more practical language or functional language. So in that broad domain of kind of pragmatics, we can also look at more kind of detailed social emotional skills and social emotional functioning. So that might include, say, what we call affect or emotion recognition. What is this child or this individual's ability to study faces or survey facial information and identify individuals that are happy or sad or angry or disappointed? So we have the capacity to measure some of those capacities, or some of those skills rather. In addition to language, IQ, memory, and so on, we also can spend a considerable amount of time, and we usually do, looking at emotional functioning. And kids with autism, adults with autism, have a higher co-occurrence of anxiety disorders, for example, than many of the other conditions that we evaluate in our clinic. So we're always looking for and concerned about OCD. We're concerned about generalized anxiety. We're concerned about social anxiety in particular, phobias, so on and so forth. So a comprehensive evaluation obviously would cover the emotional realm as well. Not to mention adaptive behavior and more kind of practical day-to-day skills that are involved in sort of navigating the environment, getting ready for school, manipulating utensils during eating and dinner time. So in that behavioral dimension there, we are assessing it primarily through rating scales, questionnaires, inventories, less so in terms of direct observation, and rarely, unfortunately, are we equipped to do so in the patient's natural environment. So let me maybe use this as a transition and have Dr. Nepo, our behavioral specialist, talk a little bit about more functional, adaptive-based assessment. And then at some point, I think we'll circle back and talk a little bit about the implications of what some of our test findings may play out in terms of program development, school recommendations, things of that nature.
Sounds great. Thank you, Dr. Albert. And so we read all the Dr. Albert's team, all the recommendation and assessment. And and then further we dissect and conduct additional assessment and observe the client's behavior and try to find out the functions. So 3 main assessment we conduct come to our practice. So the first one is the functional behavior assessment. So all the challenging behavior has function. There's a reason for why individual engaging in certain behavior like crying and tantruming and aggression. So 2 major functions. One is get something, and getting attention, getting item, getting some kind of sensory input. And the second function is getting out of something. Try to get out of the demand and the task and the homework. So there's a 2 main functions. So those 2 main functions, we can gather information through indirect assessment, reading Dr. Albert's team's assessment and report. And also we can ask stakeholder. Sometimes we can ask individual why this behavior is happening. And most of the time you can ask parents and teachers. So what we are looking for is what happened before and after the behavior. What's we maintaining those challenging behavior? And then second way to gather those information is the direct assessment. So we observe the behavior and in the natural environment, what's going on in the environment and what happened before and after the behavior. And then once we identify those possible functions, we can program and appropriate treatment. So with the behavior reduction program, we have to always identify the replacement behavior. What's functional equivalent and more appropriate behavior? If the child won't get something, teach the child communication skill. May I have a cookie? If they want to get out of the task, can I have the break? Can I take a break? I need help.
So Dr. Kaori, just to kind of thread the needle through, what I'm hearing is from Dr. Mintz is we first look, there's a lot of biological aspects that not only do we have to rule out, we have to try and see whether or not there's any impact from a biological, neurological perspective. Dr. Alberts takes some standardized data and information and looks kind of holistically at performance in some respects. And then does that line it up for your behavior assessment next to assess, obviously, if there's challenging behaviors, but do you also utilize some of that information from the neuropsychological report to kind of figure out some of the strengths so that you can build that in? Is that typically how it works?
Yes, definitely we are looking at the other medical factors, and if a child's having a headache or toothache, that would affect the behavior. So we have to rule out those biological cause for the certain behavior, and then also thread through with Dr. Albert's team, and we'll conduct a skill-based assessment as well. So we'll across all domain, communication, pre-academic, social, discrimination, self-help, all the domain Dr. Albert mentioned, we'll actually conduct assessment and actually do the trial and see the child has actual skill or not. Then we can target those skill acquisition goal and also the behavior reduction goal with the replacement behavior.
And so let me just ask Dr. Alberts, and I'm sorry to go a little bit off task here, but this is interesting. So the information that you get, Dr. Alberts, can that be then translated into what the behavior analysts are seeing in order to kind of drill down a little bit further? How does that work together with your assessment?
Yeah, well, we certainly hope so. The goal of our assessment is obviously, as I said at the outset, fairly multidimensional. A major aspect of our evaluations obviously have to do with kind of a precise diagnosis, or at least as accurate of diagnosis as we can get. I think we'll probably come back and talk about that here in a moment. But in terms of our evaluation of skill levels and skill status, our goal in evaluation is in part to kind of give our behavior colleagues, our behavior team, our education colleagues in the school setting, a head start, really, sort of a baseline, a foundation on which to maybe save some time and develop a treatment plan without one having to do a repeat or a duplicate type of evaluation. So for example, if we do an academic assessment with a child, we can get grade level proficiencies, we can get age level norms to kind of describe where they're at functioning in terms of developmental level and so on, with the expectation that our behavior team will then take that data, and if they are working in supporting the child's academic curriculum, it gives them clearly a lot more direction in terms of where to start, as opposed to redoing an assessment or redoing an evaluation. Same thing has to do with, Dr. Kaori was mentioning ruling out some of the medical, potential medical contributions or influences to aberrant behavior, ruling out headaches, ruling out, say, sinus congestion, ruling out GI issues, if, if there are behaviors that seem to be related to, say, self-injury and so on. Part of our evaluation, as I had mentioned at the outset, concerns a lot of attention to emotional factors. So, we've got kids that we see who are, say, socially anxious, or they have OCD features and so on. So we always find it helpful to try to sort of separate, distinguish, tease out the contribution that just anxiousness, for example, might play in a child who is socially inhibited and struggling to engage with peers or struggling to engage with others. So if we can give insight to our behavior team that we feel that, say, the child's social interaction deficits are, say, significantly influenced, not just by, say, a communication impairment or trouble with emotion recognition or affect recognition, but might also be influenced by this sort of nervousness and tension and anxiety. We can then, look at ways of intervening to reduce that child's anxiousness, their social anxiety. That makes the sort of the behavioral skill training a little bit more, I think, efficient, and even makes the child a bit more amenable to benefiting from those services. So in essence, we try to give these, our colleagues in the behavior realm and school realm kind of a head start and a heads up, and hopefully point them in the direction of where we see the greatest need, and oftentimes that's where sometimes the greatest deficits lie. But at the same time, we want to capitalize on whatever strengths we can identify in the evaluation as well, and tie those into some of the skill development activities that are going on in their program.
I just want to add to that too. This is not a one-way street. This is an interconnected assessment. Too often with autism, if they're presenting, let's say, with problematic behaviors, the knee-jerk response is to suppress the behaviors without understanding why they're occurring. And often that is unfortunately just with medications, and often the medications have toxicities and things aren't going well, and there's just more medication, and it gets to be a vicious cycle. But for example, in a situation, let's say, of a self-injurious behavior, or an aggressive behavior, by understanding, for example, the functional behavioral analysis, if that's telling you that there's a function that's easily amenable to a behavioral intervention, that would be the first step, rather than going into a lot of medical treatments and other things. But if the assessment is saying, well, this looks like it's more automatic or biologically driven, then the next step would say, well, why? Let's say if it's a self-injurious behavior. I have many patients over the years where the behaviors are such that most professionals, whether they be medical or other, don't even examine the patient because they're too difficult. The behaviors are too difficult, and they just say, "Oh, I can't get near them. It's just the behavioral issue." But there's other ways to assess to determine that. But maybe you could determine there might be something simple. I've seen people with tooth abscesses. I've seen inflammation in the lungs and elsewhere. I've seen even too much earwax. That can be bothersome, or a corneal scratch or something. So sometimes if you could identify that, or in other areas, maybe a little bit higher functioning, like Dr. Alberts was saying, maybe there's an emotional factor that needs to be addressed. But often you are left with a biologically driven issue. And in fact, in most cases, you're going to have a combination. You're going to have biologically driven behaviors, but also that are environmentally influenced. So you might be able to get some benefit from behavioral interventions, maybe not complete. You might be able to get some benefit from medical treatments and other approaches, but not necessarily complete. And the combination is much more powerful. So this isn't interconnected, and it could go back and forth. We might start a medical treatment, let's say a medication, for example, something simple, and by understanding the quantitative behavioral results, if somebody's collecting data, for example, that might suggest whether that medication is working or not, or from our investigations, possibly something like a certain type of genetic variant might tell us that certain medications might be more useful than others. So it's all interconnected, and it doesn't stop just at the initial evaluation, because these are chronic conditions. They're going to be good points and bad points along the way. Hopefully the trend will be good, but there'll be ups and downs, and we have to always reassess and try to figure things out.
Yeah, that's a great point. And especially when we working with the individuals with autism, a lot of time they diagnosed with seizure disorder, and sometimes absent seizure looks like they're not attending, and we are instructing them, but ending up we have to make sure we don't have any seizure happening during the instruction, and then I can connect with Dr. Mint's team, and so make sure those assessments done, and then those medical piece addressed. So it will help on the instructional piece and skill acquisition piece.
Let me even add a little bit to that, Corey, to follow up, excuse me, on what Dr. Mintz has said. Part of this process, or a major part of this process, oftentimes entails, trying to identify, again, strengths and weaknesses, and oftentimes, impediments, or what we might identify as barriers to optimal engagement in a behavior-based program or a school-based program, and so on. So getting back to this whole issue of attention, kids with autism previously, at least prior to the most recent diagnostic manual, if they had autism, they couldn't be diagnosed with ADHD. And attention problems and impulsivity and so on are all kind of considered part of the package. You know, in the 2017 revision of the diagnostic manual, it sort of all of a sudden was okay to diagnose ADHD in kids with autism, and then that opened up some, you know, opportunities for you know, specialized treatment and focused treatment on that as a problem. So as part of our evaluation protocol, we do spend a lot of time on attention. And I had mentioned, I think at the outset, that we can look at visual attention, auditory attention, sustained, divided, you know, multiple facets of attention. Because as we anticipate these kids participating in, you know, directed treatment services, be it therapy, be it, you know, a discrete trial, you know, intervention from a behavior staff member or so on, we're always concerned and curious about that individual's ability to sustain their focus, you know, in a quality way. Because we look at attention as really setting the limit on somebody's ability to take full advantage of an instructional opportunity or a therapy session and so on. So I just wanted to kind of point out that attention is too often, I think, a neglected dimension in terms of understanding the neurocognitive profile of kids with autism and adults with autism for that matter. Sometimes, you know, there may be an indication for medication treatment. Sometimes it might be a matter of reducing environmental stimulation. Sometimes it might be teaching self-regulation skills to the child or to the adult. Sensory modulating, you know, devices and the like can make a big difference for these kids in this population. But sometimes not. Sometimes the medication treatment is oriented. But again, the overall goal, I think, is to identify what is getting in the way of us as providers being able to provide sort of the maximum dose of treatment, the maximum dose of a therapy, talk-based therapy, if it's psychological counseling and so on. So we always want to be attentive to that and you know, intervene medically or behaviorally or otherwise when indicated.
So yeah, I think it goes to the concept that one size does not fit all. We really have to tailor things and individualize them. Autism is a broad diagnosis. In fact, you could provide a diagnosis of autism regardless of what causes it. So you're really dealing with a heterogeneous group of individuals, again, with many, many different ways they reached the diagnosis of autism: biological pathways, clinical pathways, environmental pathways. And therefore, the treatments can't be broad-based. There is no treatment for autism. In fact, some people refer to autism as autisms with an S at the end. That's, you know, plural, because there are so many different, from a biological and clinical perspective, there are so many different subtypes, more than just what the DSM would offer. So that's just a broad label. And then from there, you really have to individualize and personalize everything. And that's where you'll get better and more successful outcomes. If you're just providing somewhere that you see, you know, you see it all the time, but somebody has the new treatment for autism, and it really doesn't make sense from a medical, clinical, behavioral standpoint. It's, you know, the question is, well, what subtype of autism are you talking about that this treatment is useful for? And from a sort of clinical profile, biological profile.
So I am going to stop just a moment there because I know you guys get all excited about this, and I love hearing about the back and forth. But just to call attention to the audience that thank you, Colleen, for sharing some very valuable resources that are on the Autism Speaks website with both behavior interventions as well as resources and challenging behavior toolkit. I know that we refer our patients to the challenging behavior toolkit quite frequently. I'm going to pull it back to the original intent on our discussion this evening. And again, it's about building skills in order to reduce problem behavior. And I feel like we've gotten a little bit on the diagnostic end of things, like, you know, about autism, looking at some of the strengths, then looking into a functional behavior assessment to possibly, you know, abate any, you know, problematic behaviors. But how about the idea of skills? How does that correspond? And Carrie, I'm going to punt to you on that one.
Sure. So the skill-based assessment that we use several assessment tool, and the one is like ACE skill assessment and core skill assessment, and those are developed by New England Center in Massachusetts, and it's covered like, you know, foundational skill. And with that and all the domain, like I mentioned earlier, and the communication, academic, and self-help, and all the domain are covered, and make sure and child doesn't missing any missing any skill, and they need to further develop their skill and more complicated skill, a complex skill. And
So-
other
I'm
people.
sorry to interrupt you, but the way that I understand it is the functional behavior assessment specifically looks at the problematic behaviors in context of what's going on. But then the skill assessment, so to speak, whether it's the ACE, whether it's a VB map, and we will go ahead and put some of those up into the chat like somebody asked. Those are kind of two different assessments that look at various aspects of performance, Kaori.
Yes, like in a skill assessment, like, make sure, like, we have, like, foundational skill, but
Mhm.
also, like, go hand in hand. And because, like, to mediate those challenging behavior, we have to teach that replacement skill, like a communication skill, like, requesting for break, requesting for cookie. So, like, it's go hand in hand, like, especially communication skills are definitely most important skill to teach anyone. Because, like, think about, like, going to the different country. Like, I came to here in United States from Japan, and initially, like, you don't know how to speak, and you don't understand anything. Like, think about going to the different country, doesn't speak language, and you get frustrated because you don't know even, like, ask for, like, bathroom, or where is a hotel, right? So, like, those communication skills, like, go along with, like, challenging behavior. If we can effectively teach a communication skill, we can definitely reduce challenging behavior as well.
Thank you. And Dr. Alberts, does, once we kind of go through, I think, thank you, Dr. Vince, for kind of elaborating that this is full, comprehensive, and we continue to work together, and it's a dynamic process. But after we get the skill assessment, is there a point where, Dr. Mintz, you come back in, and Dr. Alberts, you come back in to see, I hear a lot of times about recovery and cures and things along those natures. Could you touch on that from both the biological and psychological perspective?
Yes, let me defer to my colleague, Dr. Mintz, to comment on the biological
Okay.
regarding autism recovery or
This wasn't going to be all softballs, guys. Yeah, got to be in some hard ones.
Well, so I mean, once you have a better understanding of an individual from their behavioral profile, their clinical profile, from a biological perspective, it's a little bit like an onion and trying to peel off the layers of the onion until you can get to the inside and understand what's generating these problems. And again, it's usually a combination of factors, both internal, which is what the biological is trying to figure out, as well as external. And at the same time, you could have biological predispositions that make you more susceptible to environmental factors as well. So some of the sort of approach from medical biological approach is to do some core investigations. One that has come really to the forefront and has become really almost, I would consider, in my mind, it's considered a standard of care, is genetics. Probably a good 80% of individuals with well-diagnosed autism spectrum disorder without any other known issues that may have occurred, after they were born or prior. It seems to be a genetically predisposed situation. Now, in some cases, there are genetic variants that are working either individually or in combination that are the cause of the problem. In other cases, these are sort of risk factors or contributors to other issues as well. So genetics is really create a new understanding of autism, and it's interestingly enough, the technologies have advanced so quickly and so fast. It's really a rather simple test in the sense of getting it done. The sequencing now, you can now sequence the entire human genome within an hour. It used to take about 10 years, was the first genome, it took 10 years. And that wasn't that long ago, that was about 20, 25 years ago. And now it can be done in an hour. And of course, that also has been associated with tremendous drops in pricing. It could still be somewhat expensive, but insurance companies are coming around and covering it more and more. There's different types of genetics. That's a talk unto itself. But in general, understanding the genetic profile or the genetic variants that may be causing or contributing to autism is very important. And I must say also, I have to add that to do that, it's not so much getting the test, it's actually interpreting the test and taking that information and translating it into something that's clinically useful. And that's not really done at too many centers. And that's a real challenge because the amount of information that you get from some of these newer and more advanced DNA sequencing tests is really amazing. And we're getting, if people understand sort of the amount of data, this could be a terabyte of data. It could be, you might get 20, 30,000 genetic variants back. And of all that information, you have to make sense about which of those variants are important, which ones might be causing some issues, which ones might be what we call actionable, which means it might suggest certain other tests, it might suggest different treatments. It might provide some diagnostic information. And actually just by creating a molecular diagnosis, that in and of itself is very important because that could then sort of end what we call the diagnostic journey. It might avoid doing a lot of other tests. I would say 20 years ago, 15 years ago, maybe even 10 years ago, individuals with autism, we used to do these really tremendous, large, and somewhat invasive workups. Lots of blood testing, urine testing, sometimes muscle biopsies, skin biopsies, all types of things. And nowadays, if you do the genetics, and then we would do genetics down the line, it was more primitive testing and it didn't give us as much information, but it would be after doing a lot of testing to say, well, maybe there's a genetic cause, let's look at genetics. Now the pendulum has swung and it's more of a genetics first type of approach because that right there can tell you what the answer is without all that other testing. So you could avoid a lot of testing too by doing that up front. So that's a very core feature of understanding autism from a biological perspective. The other thing was mentioned, Dr. Nepo mentioned that a lot of individuals with seizures in autism, there is a high incidence of seizures and maybe even a higher incidence of individuals who have electrical changes in the brain that are not being clinical manifest by what you would typically call seizures, but could still affect their functioning. So sometimes you want to look at the neurophysiological function of the brain, and that can be done non-invasively with types of what are called EEG or electroencephalograms and other approaches. Imaging of the brain, things like a magnetic resonance imaging and things along those lines, sometimes are indicated. They're not absolutely necessary in all cases. In our hands, it's usually more looking at the EEG, and depending on if there's abnormalities, that might suggest an imaging study that might be useful. Most of the findings in neuroimaging studies are not usually something that are actionable or something you could change. They might show some fixed finding that might help with diagnosis, but occasionally there are things that can change. And again, it depends upon the clinical situation. Everything has to be individualized. As far as other tests, I mean, there's a number of things that can be looked at depending on the individual. There's, a lot of individuals have immune issues, immunological issues that could be assessed and measured, gastrointestinal problems, hormonal imbalances, metabolic changes. So there's a lot of tests that can be done to understand and create a biological profile. Dr. Alberts, are you going to say something?
Yeah, I just wanted to kind of bring things back a little bit to this concept of recovery or improvement or substantial change. For those of us who have had the benefit of being in the field for 20, 25, 30 years, we've seen kids that we've tested and evaluated at an early age obviously grow up and the like. And there's certainly in my career, I've had the benefit of certainly seeing a handful of kids and sort of track them, monitor them, reassess them over the course of their lifetime. And, many of these kids are significantly different in terms of their cognitive status, their social interaction skills, their academic achievement, their vocational success, and so on. So I won't speak, too directly about the whole concept of recovery or of remission or recidivism, whatever. The diagnostic manual actually doesn't have a provision in place to take away an autism diagnosis. So that's somewhat of a barrier, at least from that technical sort of standpoint. But kids who get the right treatment at the right time and delivered with fidelity, at a level of intensity that it fits with their individual needs and their profile, can benefit substantially, so to the point where they are attending regular schools, they're IQ, say, is normalized. They don't have interfering social deficits. They test just like a neurotypical kid on many of our measures. They are diverse, obviously, as is the general population of individuals out there. So, with the right treatments, with the right intervention, based on the right diagnoses, understanding and appreciating any underlying neuromedical type of issues and so on, with a kind of a right package, these kids have the potential to potentially live as independent and fulfilling life as the rest of us. So
Dr. Alberts, I feel as though between you and Dr. Mintz, we had the very best, most walk that fine line of answering but not answering some of the questions. I think what you're saying is it all depends. Again, back to the very beginning with Dr. Mintz, it depends on the intervention, what the cause is. I think, we all say that we meet one person with autism, we meet one person with autism. But I think you say something that gives us hope. I'm going to pivot right now to some of the questions that are coming in, because this is a very robust discussion. I have two specifically for Dr. Kaori, because we talked a little bit about the FBA initially, determining what the function is of the problematic behavior. There's a question regarding, and I'd love to actually hear from Dr. Kaori as well as Dr. Alberts, on whether or not an FBA takes into consideration sensory challenges or sensory, processing disorder challenges as well. Dr. Nebo?
So we definitely account for sensory input. Again, they try to get some kind of sensory input, and it's for the getting something and getting out of something, of the avoid those loud noise, a crowd and stuff like that. And so we definitely account for that, but I'm not sure processing part. Dr. Albert?
Yeah, I'm going to have to admit that we pay attention to those issues. We're sensitive to, a child's autonomic nervous system oftentimes being overly reactive to the environment, from auditory input, as you said, Kaori, to tactile input and so on. We don't have particularly good ways of quantifying that or documenting it. A lot of the assessment instruments rely upon parental observation and input from others in the child's environment. So our kind of default, at least from a neuropsychology standpoint, often is to identify it as a concern, put it on the diagnosis list as provisional sensory processing deficits or sensory processing impairment, or as I said, we oftentimes call it a disorder of the autonomic nervous system. And then, try to advocate for the parent to, through the school system or privately, secure an occupational therapy evaluation. OTs are great at motor, fine motor, gross motor, skilled praxis type evaluations and interventions, but they are also, I think, more sensitive than any other discipline to the sensory processing piece. So we try to cover as much ground as we can, but that happens to be an area that we always look for input from our other colleagues.
Absolutely, but I do think we account for the differences in behavior under those stimuli. Is that correct, Kaori?
Yes.
So we attend and we take data on that.
Right.
I think
that's reaction to different sensory input, any sensory noises and tactile input that they try to avoid. So either get something or get out of something. So we definitely take that into account. But I'm a behavior analyst, in the processing part, we don't look inside and we can observe inside.
so. We stay within our realm of expertise.
Yes.
But I have seen some functional assessments, and this is just to the group, full disclosure, I'm a behavior analyst as well, so I get to chime in every once in a while. Sometimes we do, change the lighting, maybe manage some of the auditory things that are going on if we see that there's a direct effect on particular behaviors, for example. So it's all a matter of what and attending to certain things. But the goal is, again, to develop a treatment plan that accounts for those things, but that's not the core. We want to develop those skills that maybe it's tolerating certain, auditory, maybe it's, long-term being able to advocate for themselves and say, I want the lights down. Our goal is to get an individual towards independence. I think, from our perspective, we have the easy job. We just look at what we have right in front of us. We take data on all our behaviors. We leave the inside stuff to the medical professionals. So we do account for that. Having said that, we don't particularly treat that is the way that I would put that. Sorry to jump in, Kaori. That's one of those favorite ones of my own. But there is another question as well. I put some assessments in the chat box regarding the behavioral skills assessments, because it seems as though that's a very high interest, and it came in some of the questions as well. Beyond the VB map, Kaori, can you describe anything that's used for individuals after age 5 from a language or a curriculum standpoint?
The curriculum standpoint, a core skill assessment cover about age 5, and also the essential for living cover like a more foundational functional skill and adaptive skill.
Okay. And I'm going to put, is it okay, the ACE, or the Autism Curriculum Encyclopedia, is a very robust curricula that goes from, developmentally from, I think, about age 4. Is that right, Kaori? 4 through 21 and beyond. There are skills in there.
I think it below 4 too. So it's like all the foundational skill like child need to develop, and before they develop other more complex skill. So they can cover everyone.
The essentials for a living as well. The ACE or the Autism Insurance has the Autism Curriculum Encyclopedia. It's a mouthful, so we call it the ACE, has a very robust core skills assessment that we use. Whether we're using the ACE curriculum or not isn't the important part. It's that there are a bunch of skills that are broken down, researched, and it scaffolds, and one skill builds upon the next. Dr. Alberts, do you find that there are any additional assessments that change as they get a little bit older? Does anything on the reevaluation change from your perspective?
Well, one of the things I did want to mention from a behavioral standpoint, to the extent that neuropsychologists, assess functional behavior, we do incorporate into our evaluation typically a rating scale, a parent completed rating scale on adaptive behavior called the Adaptive Behavior Assessment System. The Violent Adaptive Behavior Scales as well is something that we also use. So, we have measures that, we can administer to toddlers, 2 years of age, sometimes even younger, through adulthood. So as we monitor the developmental progress and the skill development of these patients under our care, we're updating to, adolescent measures to adult measures and so on. So we do kind of track folks over the course of of at least through early adulthood as best we can. But one related question to that, I think, Kathleen, I'd like to make a quick comment on is this whole notion of, after the diagnostic evaluation, diagnostic assessment is complete, and that's a lengthy and sometimes complicated process, as we've discussed. When do we sort of next, or what's the sort of the next milestone or the next trigger for a reevaluation? And I just wanted to make, again, a couple of quick comments about that. For those kids that we see who are toddlers, who have, say, been through the early intervention program, the birth to 3 program, at age 3 or so, those kids are oftentimes, and if we've diagnosed them, say, with autism in that, say, 2 to 3 year age window, at age 3, they're often then reevaluated by their school district to establish eligibility for preschool. Preschool child with a disability would be sort of an IEP designation. When we see a child who we've diagnosed with autism, they undergo school screening and are not identified as a preschool child with a disability, that certainly raises a red flag for us. That could be a good sign. It could be that the child's skills have developed sufficiently in whatever interval there's been an opportunity to provide some behavior and speech language and other services. But sometimes the criteria that is required for a child to meet eligibility for an IEP at the preschool child age, some kids don't meet it because they got 1 or 2 questions correct on a task, or a rating that was completed by a parent or a caregiver fell just above that, say, 25% deficit cutoff or 33% developmental delay in another area. So if a child with autism at age 3 is not classified or meets eligibility criteria for an IEP, then we would certainly want to take another look at them. Same thing for that child going into kindergarten after they've completed their preschool program. If they are reevaluated by the school district, which typically happens, and they are found not to be eligible for services, again, that could be a good sign. It could be very positive, kind of prognostic sign. But we know that these kids generally need services, whether or not they satisfy the strict, we call discrepancy criteria that the school tends to look at. So they're looking at oftentimes raw numbers and not necessarily at the child's behavior qualitatively or functionally in terms of how it impacts their overall adjustment or even the family's adjustment. So entry into kind of pre-K, entry into kindergarten. Once the child is has an IEP, there's a triennial evaluation process that is federally mandated. Our position, or at least my position, is that waiting 3 years to monitor a child's progress formally and objectively and quantitatively, you could be missing opportunities. You could be missing skill deficits that may have been clouded by behavioral issues or skill strengths in another domain. So I think there's not a good rule of thumb, but at least every couple of years, I think there's justification for at least a targeted assessment, if not a comprehensive assessment. But this is a population that we don't want to miss sight of any aberrant deviations in skill development. We want to kind of keep pushing the envelope. Parents need a lot of information to advocate for services. So, reevaluations, I think, are necessary, and the timing obviously depends on the child's needs.
I have an interesting question that I think is very appropriate for you, Dr. Alberts. Why is it that an assessment scale used for either speech therapy or occupational therapy, why do they hardly move at the annual evaluations? But it's obvious that the child has made specific progress. I think it would be helpful for you to speak about that.
Yeah, quickly, that's sort of a statistical question. One way of sort of working around that is, instead of relying upon the conversion of the child's test performance, they get points for basically every correct response that they generate in a test. Those raw score points then are converted to a standard score or a scale score or a T-score or a Z-score or whatever the system calls for. So for a child to have a expressive language vocabulary of 85 in grade 3 and have a expressive language vocabulary measured at 85 at grade 5, even though we know they're making progress, they still are making progress because they're now compared to kids that are, say, instead of 8 years old, 10 years old. So we want to see kids moving in that direction. Sometimes it's okay that standard score doesn't move as far along the continuum as what we would like for it to be, but sometimes that just means that they haven't caught up yet to their peer group. But the good news is they haven't fallen further behind.
Okay, Ray, would you like to chime in on that one, just to tie it together with skills?
So skill-wise, we take data, correct data, each goal, every session. So our measurement is much more sensitive in how the child making progress. And we did, based on that, we determined, is the interventions working? Did the child master the goal? And we can move on to the further complicated skill or complex skill. And if the communication is improving, can we expand on the social initiation, social skill? So for us, we have a much more precise and ongoing measurement, and we sensitive to the child's progress, and our decision based on all the data we collect on daily basis.
Yeah, I think the key here is that, all the way from biological through behavioral, it's a hand in glove approach to make sure that we're holistically looking at the child that we're working with. But the emphasis, regardless of whether it's, psychological, behavioral, is, taking those strengths and attempting to remediate the deficits that we have. There's been a couple of questions about the VB map. Again, we don't propose that one is better than the other. A VB map is not necessarily a standardized test, but it gives us a list of skills that can be built upon. So again, it's just a matter of looking at what are the holes in any one individual's skill set so that we can attempt to remediate that using the information we get from the neuropsychological report that says, oh, we have strength in this particular area. So the behaviors can build programs for those skill deficits while considering the strengths of the individual that we're working with. But always comes back to you, Dr. Mintz, that we have to rule out and never ignore the biological aspects. Is that about accurate? Did I summarize that?
I think so. That's very accurate. Yes.
Yes, and Colleen, from your perspective, you've been putting a lot of different things into the chat box. I know your toolkit has been super helpful. Do you mind discussing that briefly as you're showing the links here?
Sure. Well, first of all, I want to thank you guys for inviting us to participate in this. I love your theme of highlighting strengths. That's very important for families, especially as they begin this journey. So I have just a plethora of resources that we're going to make available to you guys as a follow-up. But the first thing is the Challenging Behavior Toolkit really is a phenomenal resource. It goes really nicely with everything you guys are talking about today. It really contains all of the information that you're talking about. But, you know, one of the things that we find is that many people don't even understand all the fabulous resources that Autism Speaks has. So there's a whole section on challenging behaviors on our website, but I've broken the links out and I'm going to send that as a follow-up version so that you can all access those and not feel like you have to copy the entire chat, because they're just really, really good resources. The other thing I want to remind everyone is that we have an autism response team. That autism response team is available from 9 a.m. to 5 p.m. local standard time. It is a group of individuals, all who have a background in autism, a degree related to autism. We get phone calls from the entire community, whether it's a parent, a professional, or an individual with autism. We also have 100-day toolkits in 2 different versions. We have one for young children and then one for school-age children that literally walks you through what to prioritize those first 100 days after a diagnosis. We just finished a 3-part newly diagnosed series that I have links to that I'll also include in that follow-up document. And we just recently started a Facebook page for newly diagnosed families that is also a great place for people to meet and find support. So we have a lot of different things, just like I said, a myriad of resources that we're happy to share, because nobody should ever feel alone on this journey. And I really love the collaborative nature of your business, because it's so important that everybody, you know, work together for the benefit of the child and or adult that is diagnosed with autism that's you know, needs this assistance. So thank you for everything that you guys do. It's really important.
Thank you, Colleen. And we refer to your website quite frequently, both for our parents, our patients, as well as our professionals. We do direct them.
Yeah.
So thank you very much for everybody who joined us on this Wednesday evening. We will be following up with some resources. Like Colleen said, we will send out a post-webinar email, and you'll be able to access some of the things that we talked about. And we are always happy to answer as many questions as we can kind of take. But have a great evening. Thank you, Dr. Mintz, Dr. Alberts, and Dr. Nepo, and Colleen, as always, for your support and for what Autism Speaks does. Everybody have a great, fantastic Wednesday.
Thank you, everyone.
Thank you.